Welcome everyone to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for November 16th, 2023. We have no CME activity code today. This conference will be recorded. We have nothing to disclose. And as usual, patient privacy is preserved by changing any identifying information. I want to start today. I'm going to share my screen. I want to start today with a little presentation. Let's see if I can do this here. Share screen. Can everybody see my screen?
Yep.
Great. Well, I want to pay a little tribute to Dr. Lewis, who passed away this last weekend at 87. He was fighting heart disease for a long time, and he was in Chicago. Died very peacefully with his wife at his side, but he was really a very important person to all of us, and very important person in the realm of biopsy conference, which is without him, none of this would be possible today. He will be greatly missed by the nephrology community and all his friends and colleagues here at work. See if I can. So Ed was born in New York City. And I think he was born in Queens. Then he went to college in Canada. He went to McGill University in, I guess, 1954. And he got his undergraduate degree there. And then he went to medical school and also stayed in Canada in Vancouver, University of British Columbia in Vancouver for 4 years. He then came to the States and did his residency at Johns Hopkins from 62 to 65. And from there, he just moved a little bit south down to Boston and oops, skipped a step there somehow, but to Peter Brigham in Boston, became a research fellow there, stayed on at Harvard, was chief of the division at the Thorndike Institute at Harvard, and then eventually came to Chicago in 1971, and it was the University of Chicago. And he stayed there for about a year. His first fellow was Bill Kauser. I'll show you a picture of him in a minute. After 1 year, he became chief of nephrology at University of Chicago, but only stayed there about another year, and then came to Rush, where he became the director of nephrology and stayed the rest of his career. And this is what I want to show you, a little history of Rush nephrology, because I think it's important. It's important for today because we also have a case of lupus today. But on the left, we have the title page of a book called Lupus Nephritis, done in 1957 by Dr. Murky, Dr. Kark, Dr. Pirani, Dr. Pollock. You can see the pictures on the left in that order. Interestingly, I think Steve Corbett found this copy in the university library. It says, "To the Medical Library of Rush Presbyterian with compliments of the authors," and it's all signed by each of them. And it was just, this treasure was sitting in there, and fortunately, Steve has it. But it was the original book called Lupus Nephritis. Now we're talking about 1957. I was 1 year old. This was the beginning of renal biopsies, which Dr. Kark really brought to America. And the pathology and the clinical pathological correlations all brought together by Dr. Murky, Pirani, and Pollock. And at the time, they were at a place called, Presbyterian Hospital, which was associated with the University of Illinois. So it's kind of a combination then. But by the time Ed got here, Kark was still around and still practicing, and Ed was it was now Presbyterian St. Luke's Medical Center. And with that in mind, with this history and this great legacy of lupus nephritis, these basic guys described everything: how to do a biopsy, how to stain it, all the different patterns, you name it. Ed took it the next level with putting together the first edition of lupus, first of his own, Lupus Nephritis, in 1999, that he did with Mel Schwartz and, of course, Steve Corbett. And then they did a second edition in 2011, and these remain just incredible tomes of everything you want to know about lupus nephritis and pathology And I don't know that it'll ever be repeated or done, but they all these volumes sit in our libraries and are very important. And here's a picture of Mel Schwartz on the left. We saw Mel recently, and Bill Kauser, Ed's first fellow, by the way. And I might point out that all his fellows were downhill after Bill Kauser, including everybody on this call today, and Ed Lewis. And this was ASN when he, not only were they involved with lupus and naming immunotactoid glomerulopathy, membranous, all kinds of things. Mel was really describing the early lesion, the cellular lesion, the proliferative lesion of focal sclerosis back before we realized that this was just a pattern of injury, but we thought it was a disease. And if you look here, what's really funny is this is before posters. I remember the days when we had to pin every. This was an abstract at the ASN in '85, and we had to pin each of these up. It brings back a lot of memories of getting to your poster half hour early to make sure everything fits on the board. And you even had to bring your own push pins at the time. Remember once desperately running to an OSCO because we'd forgotten push pins. Got to bring our own. And so to follow this up, Ed formed the collaborative study group in the late 80s. And that their first big study was a controlled trial of plasmapheresis therapy in lupus nephritis. It was widely considered that that this was purely an immune complex disease, and the sooner we can get rid of these immune complexes, the better the patient would be. And so it was probably standard of care, at least at Rush at that time, that anybody with bad GN would get, in addition to immunosuppression, they would get plasmapheresis. So this trial was done, 86 patients in 14 medical centers, very well established renal pathology that was decided by several pathologists before they would be able to classify them. But basically it was a negative trial, but an important enough negative trial that it made the New England Journal of Medicine. The trial was finished in the late 80s, but it took Ed a few years to not get it published, but to write it up. I remember it was just always sitting on his desk. It got published in '92, but it was done in the late 80s. But basically when I was finishing my fellowship, I was fortunate enough to be part of this trial. Clearly not fortunate enough to become an author here, but be a part of it. And I still take care of some of those patients, believe it or not, from the original, the plasmapheresis trial. This was really defining in a lot of ways and reestablishing multi-center trials. It was extremely well designed with the NIH. And, we being Steve for the most part, and Bill, and some of our fellows probably have 20 more publications that came out of this study, just re-looking at rehashing data and looking at other aspects of it. So it played these 86 patients played a really important role in our understanding and treatment of lupus nephritis. Following that, the collaborative study group did two really major trials. And the first one was what we call the CAPTRIL trial. This was a time when Barry Brenner was doing all the rat studies with diabetics and found that two things slowed the progression of diabetic nephropathy. One was protein restriction, and that led to the MDRD study, which was a negative trial, by the way. And then the other was other thing that he found that to stop progression in rat models. This is a 5/6 nephrectomy rat model. So basically you take one kidney out and 2/3 of the other kidney, and then these rats would invariably develop proteinuria and segmental scars and hypertension. And if you protein restricted them, it totally prevented it. And if you gave them Captopril, this new drug, this new ACE inhibitor that was developed from from the viper venom of the Brazilian pit viper, I think it was, that in its venom it had a natural ACE inhibitor. So it was developed from that. And Captopril, being the very first ACE inhibitor, also found that if you gave these 5/6 nephrectomy rats this ACE inhibitor, it also prevented that. And so the first real good model for this in humans, the first time this had been used, was in type 1 diabetics, and that was the Captopril trial. And it was a very positive trial. And it really changed the face of nephrology because everybody gets RAS inhibition now because it's such an important part of renal protection. Renal protection meaning slowing progression independent of its blood pressure effect. I was fortunate to be involved in both of these studies. And then the second one was taking ARBs in type 2 diabetics. This was the IDNT, and there was also the RENAL trial. The IDNT was irbesartan, the RENAL trial was losartan. basically both came out at the same time. Both showed the same thing, and as themselves, and the same thing as did the Capital trial, that ARBs will slow progression independent of their blood pressure effect in type 2 diabetics. They went on to look then at microalbuminuria. Now that's all history. There's not a patient with renal disease with proteinuria that's not going to get put on some form of RAS inhibition to slow the progression. You know, we take these things for granted, but they had to start somewhere. And these are, you know, you could argue that few things impacted progression of renal disease more than the RAS inhibition study. And Ed took it from Dr. Brenner's rat model to the human model, and the rest is history. We recently had a reunion for all the fellows from Rush for over 50 years of fellows. And fortunately, Ed was able to make it. And that's Mel Schwartz on the right, our great renal pathologist, and Ed's wife, Julie, on the left there. He was able to make it. That was a Labor Day weekend. And we had it at the Shed Aquarium. Over 70 fellows came from all over the country. It was a great event and a great celebration of great years in nephrology, including our, with our fellowship. And here's a group of everybody at the very end of all the fellows that came in. And I'd like to point out, there's Dr. Gashti, there's Dr. Whittier, there I am, there's Dr. Baxi, and poor Steve is barely visible in the back. And of course, there's Ed, who was able to get out of his wheelchair. So it was a wonderful event. And I just wanted to, give you the whole picture to celebrate his life, what he meant to us, and what he meant to our careers, and what he meant to the world of nephrology. And I'll leave it at that. I will unshare my screen, and I think we can move on. We do have a case of lupus nephritis. Pravir is going to start it. Pravir.
Thank you. And believe it or not, we had scheduled this case a couple of weeks in advance. So kind of works. Funny how that worked out. So first of all, this is a patient, a 45-year-old woman of Asian descent, who presented to our outpatient clinic for evaluation and management of lupus nephritis. She was diagnosed with lupus back in 2002, so almost 21 years ago. And she, at that time, had presented with hair loss, joint pain, and she had a full serological workup that kind of clinched the diagnosis of lupus nephritis, systemic lupus. At that time, she did not have any kidney involvement that she could tell. We had very limited data from that admission. It was not done at our hospital. And we did know that in 2006, she was found to have microscopic hematuria with nephrotic range proteinuria, and then she eventually did undergo a kidney biopsy. Although we weren't able to review those slides, we did have notes that she had what was described as class 3 plus proliferative plus a membranous lupus nephritis. She was treated with MMF and prednisone and started on a RAS blockade. She transferred her care to Rush over in 2013. So again, this is about 10 years ago that she transferred her care. She was initially seen by the rheumatology team. She was at that time on MMF 1500 BID, lisinopril 5 milligrams. She was no longer on prednisone. Her creatinine was 0.7, albumin was 3.4. Her complements were 53 and 15, and her anti-double-stranded DNA was 165. So low complements, and that is an elevated level per our laboratories. Her urine was inactive in 2013. She had a UPC ratio of 0.1 grams per gram. And at that point, for the note, she was continuing on a regimen. 3 years later, in 2016, she presented to the emergency room with progressive back pain and lower extremity numbness. And unfortunately, she had a workup that showed she had a new diagnosis of diffuse large B-cell lymphoma, with leptomeningeal disease. Again, biopsy confirmed. She was seen by hematology and started on high-dose methotrexate and rituximab. Of course, her MMF was stopped, and it was recommended by our hematology team at that time to avoid any further immunosuppression with MMF or azathioprine for her lupus. Fortunately, SUFs continue to remain stable from the lab work we were able to review at Rush, And in 2021, she had a UPC of 0.01 grams per gram with an inactive sediment. Her complements persistently remained in the lower range. And however, she later that year in 2021, now again, this is 3 years ago, and 5 years after her diagnosis of diffuse large cell B-cell lymphoma, she had an increase in proteinuria, initially to 0.8, and then in early 2022 to 2.1 grams per gram. She was restarted on prednisone and then finally referred to our clinic for evaluation. When we saw her, she had no complaints, nothing that would concern me for a lupus flare. She had no edema. And when on checking labs, her creatinine remained preserved at 0.65, her albumin was 3.5, complements are 45, C4 was 11, and her anti-double-stranded DNA had come down to 35. And looking back, this was on par her serology. She always had serological activity with low hypocomplementemia. Her UA was inactive. I repeated her UPC and it was 1.1 grams per gram with a corresponding UAC ratio of 0.6. At that point, I increased her lisinopril and her UPC continued to trend down on follow-up to finally to a level of 0.3 grams per gram earlier this year. At that time, she was weaned off her prednisone and she was also started on Plaquenil. About 6 months later, she presented again to our clinic for routine follow-up, and on labs, we noted that she had now an increase in her anti-double-stranded DNA. Her complements were lower. Her creatinine was still preserved, but now her albumin had dropped to 2.5, and on her urinalysis, she had a microscopic hematuria with now an increase of her proteinuria to 5.3 grams per gram, which was repeated and was real. So at that time, we recommended a kidney biopsy. Review of systems, she still continued to feel well even on this follow-up. She had no complaints, no rashes, no joint pain. In terms of other medical history, nothing outside of what I've already mentioned, no family history of kidney disease. She was on lisinopril 20 at the time of this most recent eval and Plaquenil 300. Her vitals, her blood pressure was, she was normotensive, afebrile. On that exam, like I said, there was really nothing to note of. She had no peripheral edema. Her labs were repeated again. Prior to the biopsy, her creatinine was 0.75, her albumin was 2.5, her LFTs were normal. Her white count was down to 2.5 with the differential shown. Her hemoglobin was 9.2, platelets were 175 with the MCV of 90.5. Her serologic workup, I've already mentioned. We did add on an SSA, which was positive, and the SSB was negative. I did repeat her UA, as I mentioned. She did have microscopic hematuria. She had 10 RBCs, 10 WCs, and she did still have nephrotic range proteinuria with a UPC of 3.6 grams per gram with a corresponding UAC of 2.3. Renal ultrasound imaging was done with normal sized kidneys without any increase in echogenicity and really nothing else to note of.
Any questions for Dr. Baxi? We'll consider that our moment of silence for Dr. Lewis. Okay, that's good. We've got a poll. Poll number 1, yes or no? Does this patient need a repeat renal biopsy? We can't see who's voting, so everybody put it whatever vote you want in.
Ravir, while we're waiting for these results, was the lymphoma was still in remission?
Lymphoma was in remission as of 3 years ago. She was still
your
seeing
current biopsy.
Oh, in terms of sorry, yeah, at the time of the current biopsy, yeah.
Biopsy. Okay.
Yes, it was still in remission.
Right, one more vote. All right, you can share the results. A overwhelming majority says the patient needs a renal biopsy. Interesting. I'm not so sure the answer is yes. Bill, Dr. Whittier, tell us your thoughts. First of all, do you think the patient, address that question, but also tell me what you think is going on?
Yeah, I think the answer is yes as well. And I think the reason the answer is yes is there's a lot of different lesions that could be in her kidney that might require different treatment. You could argue empirically put her back on CellCept, I guess, and see what happens. But it's possible that a membranous is there, or it's possible. So I guess I'll discuss the differential. I mean, as far as any of the lupus lesions, it could be anything. It's really difficult in somebody who is on therapy to determine what their lesion is. She's had a 3 and a 5 in the past. She could easily have that again. She could have a pure 5. She could have a proliferative lesion. The presence of proteinuria doesn't necessarily predict that it's going to be a membranous. And so that's what I would consider for the likelihood of our lupus lesions. And each one of those might be treated differently. If it was a membranous only, I might choose rituximab. If it was membranous with proliferative, I might do some sort of multi-target therapy. And so I think it's important to sort that out. It's also very important to figure out what's going on with her lymphoma. The reason I'm saying that is that it's possible that you could also give her, if her lymphoma were to become active, or to prevent it becoming active in the future, or whatever the term active is, recurrence of malignancy, then maybe rituximab might be the drug of choice. That could be a dual, or possibly cyclophosphamide, which might be good for the lymphoma as well. So I think the kidney biopsy is helpful to really know if you're going to do MMF alone or not. And then the last part about this, I'm happy to say that today was the day that you did that for Ed Lewis, is because it's very possible that she has a podocytopathy. Podocytopathy could be present in any of the classes of lupus. It would just be diffuse foot process effacement, and that could be with a membranous or with a proliferative, or an isolated podocytopathy if it was just with mesangial alone or with nothing alone. And remember that, of course, is associated with lymphomas. And so that might be the first hint that her lymphoma is active if she has a podocytopathy as well. After she got her methotrexate and her rituximab, her proteinuria was 0, and she hadn't gotten anything for a while, and now she's up to 5 grams. So I think that's also in the differential, even though that wouldn't classically, if it was an isolated podocytopathy, cause the hematuria as well. But I think that's on the differential. And so I think that she needs a biopsy to help sort all those out.
Hey, Pravir, do we know what her serology did in between all this? I mean, sometimes serology never gets better. You get a clinical remission, but a serologic remission. Do you know if when she was had first induction, if the complements got better and the double-stranded got better?
The double-stranded did get better. Her complements really never got better. I mean, I think the highest she ever got to C3 was in the 50s. And C4 in the mid-teens, but she always had hypocomplementemia. Her anti-double-stranded DNA always was mildly positive to 30-40, but never above 100 after induction.
Yeah. So Bill, what is your number one path diagnosis?
Oh, boy, that's tough. I think if I really want it to be a podocytopathy
By itself.
Yeah, an isolated podocytopathy, but it just, I'm not sure that's really my number one. That's just sort of my want, because it would make a lot of sense, I think, with lymphoma and all that. I think realistically, given that there's some hematuria there, she may have some combined proliferative where she's got membranous plus segmental plus diffuse foot process effacement. So like I said, it's complicated. I guess my number one would be a 3 and a 5 with foot process effacement.
So by 3, are you implying a more segmental post-immune?
That's right. That's right. A segmental.
We don't have the path, but I just want to point that out. Oh, and by the way, Bill was kind of alluding to it. He didn't really finish the sentence, and that is appropriate today to think about because Dr. Lewis also coined the podocytopathy concept.
Yes.
So he
wanted a couple things in the dictionary, and he wanted to have credit for them. And one was ITG, and another was podocytopathy.
ITG being immunotactoid, the word, yeah. And I know most people know, but not everybody does. So I apologize. Steve, talk to me. You wrote the book, Steve. You wrote the book.
No, we edited it. That's we edited.
You wrote it. You wrote in it. You know you did.
So, one thing. Speaking of Ed, Ed always said, using the classification in patients with lupus that have already been treated becomes a little more complicated than when you see a fresh case and you make the diagnosis. Because I think the second biopsy, even though there can be hints of what was on the previous one, becomes a little more complicated to read sometimes because of I guess just because of the fact that they've already been treated with numerous agents. So I don't know, it was interesting for me. I always thought he felt using the classification was in a second biopsy was always a little more complex than if it was a virgin case. That said,
Having said
I
that too, the patient was in remission for 7 years. So you could almost think of this like,
could be.
it's not like a repeat biopsy in a way. That was,
Yeah, no, that's right. And there's this whole issue of transitioning from one lesion to another, even in patients that have been in remission. Usually it's the ones that had proliferative lesions that transition to a membranous, but we already know this patient, had membranous plus, focal proliferative lesion as well. I don't, it's interesting. I don't know. I think Bill's kind of discussed the possibilities quite nicely. I personally think what we're going to see is an underlying membranous I think what's going to be important here is what's the activity and chronicity index. Probably more than interesting than anything is how much chronicity, given the fact that the creatinine is 0.75, and we're talking about somebody that's had lupus nephritis for 10 years. I'm assuming we won't see a lot of chronicity, but you never know. The kidney has a great potential for having a fair amount of reserve. I think there could be some activity. There's 10 white cells, 10 red cells. I mean, there is definitely evidence of an active urine sediment. And so, an active lesion, it could just be mesangial proliferation plus a membranous lesion. It could just be a podocytopathy with mesangial proliferation. That could do it too. But for some reason, I'm going to go with membranous with mesangial proliferation, which in the old days would have been a 5B.
it's funny because when we put the poll out, I actually said, well, I'm not so sure the answer. I think both you guys have convinced me pretty well that the answer is yes, this patient needs a renal biopsy.
Oh, that, in deference to Ed on that one too, I don't think we should ever ask that question again.
It's not about would you biopsy. I just, this patient had
I just think it's disrespectful, Roger.
Fair enough.
I'm yanking your chain. I think in every case when a nephrologist does a biopsy, at least in our group, I think they're doing it for a good reason.
Oh, listen, it's as difficult as for me to explain what I'm saying. You're absolutely right. I would never criticize anybody doing a biopsy. I would just bring up the question, could we get away without, is there enough information here to get away and treat without a biopsy? That's really the question here. And I think the mandate is no. The answer is no. So we'll accept that answer. I will not, listen, majority wins. And this is probably the biggest majority we've had on any poll yet. So I think I'll drop that one. Anybody else have any thoughts about this? Or should we look at the pathology?
Can Bill, for some members of the audience, define what lupus podocytopathy is? I think that will be beneficial for many.
Yeah, I'm really glad you brought that up. I think it's confusing because it's confusing the literature. And so I actually may define it a different way than others. I think that most people, it was originally described in lupus when there's not many immune complexes, and it was either mesangial or possibly even a sort of a sclerosing type of focal sclerosis in the setting of lupus, and then you saw diffuse foot process effacement. They would present with nephrotic syndrome. And so he turned that podocytopathy, which we've seen is associated with nephrotic syndrome in all the cases, all the classes of lupus. And so originally his term podocytopathy was really referring to just isolated podocytopathy in lupus, which would just be a 2 or a 1 with no other immune complexes and foot process effacement. But now, and it morphed over time to include the presence of foot process effacement and nephrotic syndrome clinically in any of the classes of lupus.
And also, I mean, what it doesn't tell you is the pathogenesis of it. And I think that's
Correct.
one of the things that Ed always kind of honed in on. I mean, when we, as Roger alluded to, when we looked back, I actually got follow-up on all those patients up to 10 years, from the beginning of the study. I think the study itself ended after 5. I was able to go back and call and get a hold of, there were only like 13 nephrologists involved, and they all very closely followed their patients. So we got longer follow-up. And that's when we saw that, these patients that had the threes, which were 3 with greater than 50% involvement, which would have been a 4. I don't want to get into the trenches on this, but it would have been a 4. That's why they included them. Those patients had calcium-immune, essentially vasculitic lesions. And Ed's whole point was always, lupus is not just an immune complex mediated disease. There are other immunologic phenomenon going on here, whether we can explain it or not. And in those patients with 3s that had these necrotizing lesions, they were, for the most part, ANCA negative. So we still didn't know what was the stimulus, but we felt it had to be related to some immunologic mechanism due to lupus. Same thing with, I believe, the podocytopathy. It wasn't like we knew that there was a circulating factor, but we felt there was something immunologically active in lupus that led to this podocyte abnormality. Now, I don't know, people may have looked at this and have been able to figure out what the physiology of it is. But at the end of the day, I think his feeling was, people used to think lupus was just an immune complex disease. And in fact, when we were trying to get the Najafi paper published in KI, we got so much pushback about the idea that, 4 and 3 were independent lesions as opposed to 2 went to 3, went to 4. It was not even funny. And I think that's Ed's whole point in this, is that a disease which we always talked about as being an immune complex mediated disease is far more than that. And I think that's where, with the podocytopathy, his whole thing was, some people would say, oh, you've got minimal change coexisting with lupus. And Ed's point was, no, this may be a minimal change like lesion, but it's not minimal change disease. This is a lupus podocytopathy as an independent, or as a byproduct of the lupus, not some independent feature, if that makes sense.
Yeah, precisely. I mean, the original literature was association of minimal change disease with lupus. I mean, they really thought that, as opposed to being that. Bill put in a link to a really nice editorial that he wrote on thinking about lupus differently than we classically do, and more about the pathophysiology of these different lesions. I highly suggest.
Sorry, I will put that up. But the one I put in there was the original podocytopathy by Steve Kraft.
Okay.
One of our fellows just talking about podocytopathy, but I'll add that in too. Thank you.
Yeah, add that in, because that really gets into it. I think we should kind of move along here and get to the pathology. So I think it's time for the wheel.
Was that another, would you do a biopsy question or no?
No, that was the first question.
Hamoud.
All right.
Been a while since the wheels picked a mood. It must be a that must be a very special. I think it's Ed did that from the beyond.
Shouldn't tell him about the weights then. All right, here we go. Hamoud, can you go ahead and test your microphone? Yep, sounds good. I'm going to give you control here. Remember, there's sometimes a lag. Go ahead and click. Click on this. Yep, you're controlling.
So Hamoud, I'm going to ask you to a little faster than we usually do, because we've got a lot to discuss here. But
okay, so here I see 2 cores, trichrome stain, looking for any chronicity. I hardly see any blue material, some here, so maybe like 5%.
Yeah, very minimal. I agree.
And I see a lot of gloms.
Next slide.
Okay, now I have a H&E stain here. See multiple gloms. See a lot of cellular infiltration, some mesangial, some possible endocapillary, because I don't see any open capillary loops. It's mostly diffused. And
yeah, so the purpose of this image, we're dealing with a lupus nephritis. We have 3 glomeruli there. Does it look like it's a focal lupus nephritis or diffuse involving most of the glomeruli? The activity.
Like diffused.
Yep, right. And we'll see them at higher power where you could describe them in more detail.
Interstitium and other things, they look okay. Okay, a little higher power here. So I have a glom in the center, H&E stain again. Again, we have hepatocellular proliferation, endocapillary proliferation, some mesangial expansion. I feel like we have thickened GBMs. It's a little hard to tell. Maybe the PS will tell us better. I'm not sure if this, you can call this a wide loop lesion or.
Yeah, so in the setting of lupus, is this an active glomerulus or not? And if it is active, what is the lesion?
Yeah, it seems to be active. You have a lot of inflammatory cells and hypercellularity, endocapillary. So I can.
Yeah.
This
Right.
part,
So
yes.
it's an active glomerulus. There's endocapillary hypercellularity, like you said, and probably some wire loop lesions as well. Yep, I agree.
David, would you call this accentuation of lobularity or not?
Yes, yeah. Does look lobular.
I think it's an interesting finding, particularly for the recent grads in the audience.
Eagle eye Mario.
Another H&E stain looks more or less similar, a little bit more inflammatory cells here. Here, is there anything different in this one that I'm looking for?
Definitely a lobular appearance. Let's start with that. And yeah, quite a bit of endocapillary hypercellularity again, kind of throughout. And yeah, like you said, look at 6 o'clock. It looks like we have a good wire loop lesion right there. Yeah.
Oh, okay. Is this one?
Yeah.
Okay.
I mean, it looks like there are a few. David up around 11 o'clock too, no?
Yeah, in fact, yep, I agree with you, Steve. Yep. And on the next slide, the PAS, it'll nicely highlight them.
Eagle Eye Steve.
So here we have a PS stain. We can see the GBMs a little more clearly. Mostly they look a little thickened. Anything else?
Yes, so yeah, keep pointing out the nice wire loops right there. Yeah, there we go. Nice area of wire loop thickening.
In here.
And global endocapillary hypercellularity. There's hardly any open loops.
Yeah.
I did push Bill into saying what he thought that 3 meant, because we don't really know, but what, the point was that lesion was more of a segmental lesion, and this is definitely a global lesion, diffuse global lesion. So it does look different if that's what it was before. That was what I wanted to stress.
Roger, you got me confused. What do you mean we don't know what focal proliferative means? The WHO classification is quite clear. Please clarify it for me.
Well, what do you mean? I didn't say I don't know what it means. What I said was that we don't know what the 3 was. All we know, it was called a 3, but we don't know what their 3 meant before. We don't have that pathology. So his first biopsy.
Oh, okay.
The first biopsy was a 3 and a 5. And so I was asking Bill, what do you think that means? And Bill was saying what I thought he would say. It'd be a segmental necrotizing lesion, more of a pauciimmune. And so my point is that this looks different than what we interpret that first one to be.
Good point. I assume the first biopsy was done elsewhere?
Yeah, the first biopsy was elsewhere, and we really couldn't get those records.
Does this have a little bit of an MPGN look to it too, David?
Yeah, Eagle Eye Mario. That was just that. It looks lobular.
What? Can I be an eagle eye too?
Yeah.
Mario was he said it like 10 minutes ago.
Yeah.
He said lobular. There are other lobular GNs other than MPGN. I rest my case.
Well, that's usually the term we apply.
You're lucky that Dr. Glassok is no longer in the audience.
I can't believe Roger's not willing to give you credit where it's due. He wants to steal the credit from you.
That's fine. That's fine. He hasn't learned to respect his elders.
Well, they'd always call that the good-natured give and take of nephrology.
So here we have the silver stain, for spikes and holes and guess that there are lots of spikes, mostly like diffused
Yeah.
and holes. Yeah, mostly in this area. Some
And
here.
what does that make you think of when you see spikes and holes on the silver stain?
So basically, there are some kind of deposits in the membrane.
Well, probably a class 5 membranous component, right?
Yeah.
Subepithelial deposits.
Yeah, in the setting of lupus, yes. Yeah, so in immunofluorescence, we have IgG that's strongly positive, granular appearance, both in capillary, in the GBM, and I think mesangial as well. And IgM, IgA also positive. Here,
Yes, we call that full house positivity.
Yeah, it's got everything. So here we have an EM. Let me orient myself. Okay, so here is the GBM, looking for deposits. So I think these are electron dense deposits. Subepithelial, not sure if this is also part, but once I see
Where is that one right there, Mahood? Yeah. Where are the capillary deposits? Which side?
this, I don't see any podocyte. So like podocyte effacement. So this side looks like a subepithelial. Then maybe some endothelial as well.
Yeah, right. Yeah, both. Yep.
Both. Yeah, and I'm actually, don't see any podocytes, so diffuse podocyte effacement.
Yeah.
So,
The ones on the top over there, I'll go back, Mood. It's kind of nice if you go top like 12 o'clock. See that nice little row?
this
So,
is,
yeah, keep on going to the right. You'll see why sometimes, I mean, you can see,
oh, the
look at
deposit.
that, look at that, right? You look at those subepithelial ones, and then you can correlate that what you saw in the Jones or silver stain.
Yeah, that's true. Here, this is kind of the spike that we were seeing.
Is there villus transformation above that subepithelial deposit?
Yes. Yes. Yeah. Good finding.
Oh no, don't say eagle eye again. We're gonna go down.
I can only
Let's-
I only say it once. Once a confidence.
Okay, yeah, so here, this is the GBM. So again, we see a lot of electron dense deposits, subepithelial side, endothelial. Are these some like intramembranous as well?
Looks like we're in the mesangial notch there, getting into the mesangial area. Yeah. As you go straight up from there, you're getting, like that one there, those are subepithelial. Yeah.
A lot of subepithelial, some, and then
Mesangial there.
Here also some deposits.
Yeah.
Yeah.
And then there's another capillary loop at the far right.
Oh, this one?
Yeah, subendothelial there.
Yeah. And again, diffuse podocyte effacement.
Yeah.
For Bill's podocytopathy.
And this is even higher power. And is this a whole, all of this is a deposit?
Yeah. Well, it's kind of a conglomerate of deposits, confluence of deposits there. What do you think about, that would correspond to our wire loop. Yeah, what you're seeing right there. Those are the wire loops that we're seeing on H&E.
Yeah, significant amount of deposits here, and then I'll go all the way here too. Okay.
Massive mesangial deposits on the far right. Yeah.
Again, this is probably intra.
That one looks like a little cell process. I see a little organization, but the one below it's a deposit. Yeah. But the reason for it right in the center.
Inclusion thing, the reticular something inclusion bodies.
TRI.
What is it?
Yes, TRI.
Yeah,
Good job.
TRI. Okay.
So more than half of the glomeruli had active lesions like we saw. So the next slide will be what's your diagnosis?
Okay. David, why do we still call them tubular-reticular inclusion bodies and not interferon footprints?
Oh, probably that nomenclature, it's embedded, you know, in the literature. We've been calling it that for decades.
Okay.
No, but you're right, Mario. That at least what you're describing is at least describes the phenomenon and why you see it in other situations like HIV and other disorders where there's an increase in the production of interferon.
Right.
Yeah, so final diagnosis here will be diffuse proliferative lupus nephritis with some membranous lupus nephritis and
for Bill?
podocytopathy.
There you go. But it is a different pattern than what we were predicting, you know, because we talked a little bit about, you know, transition. And I think you would think this would be a little bit unusual. I would, to go from a pauci-immune, assuming that's what it was, segmental necrotizing lesion, to a really classic DPGN with wire loops and huge deposits.
Yeah, I mean, you know, I don't remember if it was Gary Hill, but years ago there were a bunch of papers, you know, talking about transition. I think Gary wrote one of them, whereas most of them would go from a proliferative lesion to membranous. There were some that would transition into more proliferative, and don't ask me to recount how many there are, but I know, you know, it isn't always just membranous. So, you know, you or Bill, whoever put this together may have looked that information up, but it doesn't occur. It can occur. It's just it's not as common as the transition from proliferative to membranous.
Exactly.
But to underscore what Bill said from the get-go, and this should serve a lesson to the two unbelievers that voted against biopsy, which is there is no correlation between clinical and histological findings in lupus. Number two, we learned within the last 5 years, from the work of Brad Robin and his colleagues in Argentina, that there is also no correlation with serological findings and histology. And also, there is no way to tell, based upon clinical or serological information, what histology you're going to find. So you must do a biopsy, no way out of it. And I just actually, before this conference, heard an outstanding presentation by Dr. Levine on the role of biopsy in the diagnosis of kidney diseases. And I tell you, I think that pathologists will have a job for many, many years to come.
I couldn't agree more with you. And I think even in things, you know, this gets back to the paper that Arthur Cohen did years ago, looking at the value of a biopsy, and where he surveyed nephrologists, asked them what they thought it was going to see on the biopsy, and then what the biopsy did to change their impression, to change the diagnosis, prognosis, and treatment. And it was 50-50 all across the board. Now, there were situations like asymptomatic microscopic hematuria where it was less valuable, but it was still valuable in up to a 25% of the cases. Again, I think anytime you have a question, don't, do a biopsy and answer it. Don't try and guess.
Now,
I agree.
David, you have not touched or told us about the activity and chronicity indexes. What were those?
Well, where we saw the trichrome stain and there was minimal fibrosis. There was 26 glomeruli, 2 globally sclerosed.
Did you give it an index or no?
No, I don't assign activity indices, but 14 out of 26, more than 50% had active lesions.
And the same, you don't use the chronicity index either?
No.
Wow, Howard Austin must be having a heart attack right now.
And Jim Bello died just now.
Oh, no. Oh, I was going to say, God, don't tell me he died too.
I have to agree. I just like to point out, I don't tend to trust any nephrologist from Argentina, but other than that, I think I agree with everything that was said. We have a poll too here, and in respect for Dr. Lewis, we said, how would Dr. Lewis treat this patient?
So this brings up a memory that I'm going to recount at some point.
Oh no. Let's keep it clean.
It will. Years ago at the ASN, Jim Balo and Ed Lewis were asked to be on a panel to discuss exactly this issue. And you can guess how Dr. Lewis would have done it, and you can guess how Balo would have done it. But it turned out to be not so much a knockdown drag out, but Muhammad Ali against Sonny Liston. I mean, Ed just was relentless about his position on this thing. And Jim, who's a very soft-spoken person, kind of sit there and took the punches, but then would come back very quietly with his retort. And after that was all over with, we're walking out, and I'll never forget one of the nephrologists that was in the Hirsch group, the originator of that particular group, came out and put his arm around Ed, and he goes, "God, that was great." He's like, and again, it was the good-natured give and take of nephrology. I mean, because Jim and Ed had high respect for each other, but when it came to taking their positions, man, there was no backing down, and Ed was just a lot more verbally aggressive than Jim was.
Now, talking about history, in those days, there was a Russian pathologist, Tatiana Antonovich, from the Institute of Pathology. They used to smoke a cigar during pathology conferences, and she's the only one that told Jim Balo, "What do you mean you talk about lupus? You know nothing. Listen to me." And those were the days.
I actually have a letter that she wrote and sent to Ed Lewis about immunotactoid glomerulopathy, and the paper that it was on. I actually have one from Jacques Churg as well that was sent to Ed about ITG. And the paper that these things were on were like parchment. It was the old time paper that they use for carbon, and they'd make a carbon copy out of it. But the stuff was like parchment.
So we'll show the results here. It's really 50-50 for oral Cytoxan and IV Cytoxan. Steve, what would Ed have done?
Hands down, A.
Right.
Period. That's what it was all about. Ed's feeling was, we give oral cyclophosphamide. And by the way, he always explained that in the collaborative study group, which was actually at that time the lupus nephritis collaborative study group, and then morphed into the CSG, his whole explanation as to why they actually even gave cyclophosphamide was because in the plasmapheresis group, if you didn't give cyclophosphamide, you would get a rebound after you stopped the pheresis. So his rationing behind giving cyclophosphamide in both groups was not about the feeling that you needed immunosuppression to treat severe lupus nephritis over and above prednisone. It was because he wanted to treat both groups equally and felt he needed to give that in the pheresis group. Later on, his whole point was that we give a large dose upfront in 2 months' time, 2 milligrams per kilo. For originally, the way the protocol was written is you give it for 4 weeks, and if they haven't achieved certain benchmarks, you gave it for another 4 weeks. So they would get essentially 8 weeks of it. And I think I calculated out in a 70-kilo person, you get like 8 grams in 2 months' time. Whereas with and now this is the Euro lupus protocol, which didn't exist at that time. The NIH protocol was 1 gram a month for 6 months, and then 1 gram quarterly. Initially, it was almost indefinitely, which gave them a large doses of cyclophosphamide. And then it ultimately became 6 months and then 2 years at giving it quarterly. But his whole point was you want to put out the fire right up front. So he would have used oral cyclophosphamide for 6 to 9 grams, which is about a 2-month course at 2 milligrams per kilo.
Now, with her history of lymphoma, and if you had exostocin staining available and the soon-to-be available exostocin antibodies, according to SETI, let's say that they were positive, therefore portending a better prognosis, would you choose rituximab instead of Cytoxan in that setting with that history or not?
What was in CHOP therapy?
Well, she didn't have CHOP therapy, but that would be cyclophosphamide.
No, I'm just saying that was what you would treat lymphoma with historically, right?
Yeah, no, I understand.
Yeah, I don't know, Mario. I think there's enough proliferation that I look at this as bad lupus, and
no question.
I
what
think I would
bothers
still
me the history of lymphoma.
Yeah, it is. It's fortunately been gone a long time. There's also the question, I don't know if Praveer will have a chance or it even matters if we have the time, but whether MMF even caused lymphoma, as it's not very strongly associated with cancer as opposed to azathioprine. Pravir, why don't you take over from here?
Yeah, so I know these are all great points, and I'll try to keep it short in the interest of time. The first one is in terms of MMF, that was per the hematology team, they really did not want us to use that again. And when you do go back, as Roger said, there is some debate if MMF does cause these lymphomas in these patients, because these patients have multiple different immunosuppressive regimens. Most of the data was in the transplant patients, who are a different subset of patients as compared to our lupus patients. And there is some increased risk of lymphoma and other cancers in systemic lupus, regardless of regimen. And there have been multiple patients who developed lymphomas who never received these MMF or some of these cyclophosphamide or other suppressive agents. So, but given she is young, she had this history, I wasn't going to overrun those recommendations. Now, the biggest thing coming to the biopsy was, exactly as people mentioned, my concern was, is this a pure membranous? And if it was, rituximab would have been I would have just done rituximab and called it a day. But given how proliferative this did help. The biopsy did help, and it did change my mind. And, but before that, I just wanted to quickly mentioned, rituximab and lupus nephritis, and this is perfect timing as there was a recent abstract, or at least something that was presented at ACR by Dr. Rovin, which I'll get through last week. But just to recall, this whole deal of rituximab and lupus nephritis, we've had some trials in the past. Unfortunately, this one, the LUNAR trial, was a negative trial. But just to recap, these patients there was 144 patients. They were proliferative patients. They were allowed to have a membranous lesion on top of the proliferative lesion. They were given rituximab on top of the standard of care, which was MMF. And they were given 2 doses of rituximab 2 weeks apart, then again at weeks 24 and 26. So they did receive 4 doses of rituximab. These patients in the LUNAR study did get 2 doses of solumedrol, 1 gram, within 3 days of initiation of the initial therapy. And then they were put on oral prednisone, with it mentioned there. The primary endpoint was a renal response at week 52. As I mentioned, unfortunately, it was a negative trial, but it wasn't completely negative, as we did have some other things that we gained from this trial. First of all, in terms of the primary outcome, it was not statistically significant, but if you look at it in terms of rituximab versus placebo, there was an increase, but again, did not reach statistical significance. Some of the exploratory endpoints that they looked at, including 50% reduction in proteinuria at 78 weeks, the rituximab did have a signal there, and it was a p-value less than 0.05. There's also a lower prednisone dosing. So, overall, even though this was in terms of the primary endpoint negative trial, there was some positivity in terms of our treatment of these patients. And the side note, there was a statistical significant reduction in double-stranded DNA and increase in hypocomplements. So it did improve that.
Pravir, real quick, the initial one was 52 weeks only, and then the extension is when they found those exploratory endpoints. Okay.
Yeah.
Thank you.
Yeah. So the Rituxaloop is something we always mention with, using Rituxan in lupus nephritis. And again, this was a prospective observation study. And then of course, Professor Lightstone, his group overseas. And what they do here is actually no oral steroids. So this is a oral steroid-free regimen. They did receive methylprednisolone or solumedrol on days 1 and 15 with the rituximab, again, with a standard of care of MMF. So none of these are rituximab monotherapies, but on standard of care of MMF. And so patients on maintenance steroids were completely excluded from this trial. And what they found here was that, by weeks 50, a total of 90% of the patients did achieve complete remission or partial remission by the median time of 37 weeks. And a lot of them at 52 weeks also had a complete remission in 52% and 34%. So overall, it did show that you could use rituximab as almost an oral steroid sparing regimen, and that's what she does primarily. Now, one of the interesting things that came out of later was, looking at what happened in the LUNAR trial and looking at B-cell depletion. And does this degree of B-cell depletion matter? And what we found was that, yes, there was a difference in those patients who had complete depletion of their B-cells in their complete response versus those who had incomplete depletion. So maybe part of the LUNAR study outcomes was that, there wasn't adequate depletion of B cells, as this probably it was associated with a higher rate of complete remission. And that's where we come into, and I'll skip this. This is just I just like this is Lunar ELOR guidelines. This has a nice kind of map, almost like a heat map of the treatments for lupus nephritis in terms of evidence. And you can see where rituximab has fallen is into this grade C, and it's typically used in our patients who have refractory lupus in terms of now, proliferative lesions, refractory lupus or relapsing lupus, or in cases where we can't use MMF or cyclophosphamide and we're limited in our treatment options. But
What
again, from this,
Javier, between complete and partial B cell depletion, what's the cutoff?
that's a great question. I don't know. It's a great question. I have to go back and see. I should know that. I do not know
Well,
that.
in membranous, they look at an absolute of less than 5. A CD19 count of less than 5. So we're talking pretty
It
significant.
looks like
depletion.
0 here.
Yeah, it looks like 0 here. Yeah, I don't remember a cutoff. I think it was
Oh, yeah.
complete versus incomplete. And incomplete was if you had one cell.
You're right,
That
zero.
was considered incomplete.
So they were
yeah.
using 0. I know in membranous RUMC, if they were more than 5, they would give a second dose of rituximab to try and get it below 5. So here, if it's 0, then they're talking absolute.
And remember, the Lunar trial, they did get at, again, 24 and 26 weeks, another dose of rituximab. But, coming to this B cell depletion, what has been more recent in our literature is obinutuzumab, which I can't pronounce. So I'm going to call it OBI. And this was presented at ASN by Dr. Rovin. And you could see that OBI had a much better depletion of B cells than rituximab at really all levels, at all time durations, from 2 weeks to 52 weeks, almost 96%. And none of these ever achieved 90%. So maybe getting these B cells more depleted would help. And just quickly, what's the difference between OB and rituximab? Well, besides the name, they're both, this is much harder to pronounce. Obinutuzumab is completely humanized. It's called a type 2 anti-CD20 antibody because of the new second generation. And what the biggest difference is in its activity. It has much more increased activity in terms of antibody-dependent cellular cytotoxicity as well as apoptosis, which again goes to our advantage. So just remember, Obi-Wan Kenobi, maybe it is our only hope. A big Star Wars joke. And sure enough, just on November 10th, as I was putting this together, Dr. Rovin presented this at ACR, and it's showing the post hoc analysis of the Nobility trial, which again is looking at obinutuzumab in the treatment of patients who have active proliferative lupus nephritis. And there is an ongoing phase 3 trial, which we don't have the results of yet, but this was presented just last week. And what they showed was, again, in this trial, they're using obinutuzumab with a standard of care of MMF and glucosteroids against placebo. And what you're seeing is, again, it reduced the risk of adverse kidney outcomes, even the EGFR slope decline, which has become a popular and upcoming endpoint that we're seeing in a lot of these GN trials, also attenuated the GFR slope decline, and a lot of more patients receive complete renal response. So response. So this is exciting. Maybe this stronger, more potent, I should say, B cell depletion is what we needed. And so I guess the B cell depleting therapies, even though rituximab has not panned out, I think there is still a role of rituximab in severe lupus nephritis, refractory, and when we have limited treatment options, and maybe obinutuzumab will be the next generation. You don't even get to, so in this patient, what I did is initial therapy. I did based on the biopsy. I did Urolupus regimen, and I did put her on prednisone 60 milligrams. It's too early. This is a relatively fresh case, so I don't have complete follow-up. But the other question that I think just we don't have time for here today, and maybe we can cover some other time, is what to do with a subsequent therapy, maintenance therapy. And again, MMF was not high, very using MMF from the hematology standpoint was not really an option, although again, we could present some of that data with a lymphoma that maybe is not completely linked, but really doing rituximab therapy as maintenance therapy, there's very limited data on that. And do I follow CD19 levels? I probably will. Do I do every dose every 4 to 6 months? There's really nothing on this. I know there is some data coming out on systemic lupus and rituximab, but really nothing on lupus nephritis maintenance therapy. So all of this will have to be based really on, guessing, a best educated guess, but you know, I have some time still.
Great. So I think rituximab is going to be the way you're going to have to go. I think that MMF is out of the question. I think that non-maintenance is out of the question because this patient had a really significant relapse. And fortunately, the good news is that this kind of, there was the chronicity was low. There was no crescents. We didn't see any segmental scars. We didn't see them, at least. And I think this patient is actually going to do very well. The real goal is to keep it away. You know, before you show this, I want to just say one thing. You know, we talked a lot about history and about Dr. Lewis, and the history of the biopsy conference goes back probably 50 years, even before Steve Corbett, and I was shortly after Steve. It was in a little room in the women's boardroom of this old building built at the turn of the century at Rush, and it was a slide projector. And God forbid the light went out, because all hell would break loose trying to replace the bulb, and Ed would be screaming for Helen to put in a new bulb. And but people would smoke. You know, Mario brought up the cigar reference. People would be smoking cigarettes, and the smoke would be floating through this projector. You know, going, and it was just an incredible thing. And that was our first phase. Then when PowerPoint became available, believe it or not, there was a time before PowerPoint, we moved over to Dr. Simbalak's conference room and had PowerPoint presentations, and took a while for Dr. Lewis to accept that. There's something about the Kodachromes. He just loved having that slide deck and hitting the button and going to the next slide. We also had an evolution of the wheel, because we developed the wheel because Ed could never really remember the fellows' names. And so I made a little wheel out of cardboard and I put a spinner on there with a little grommet or something. And that was the first generation. And then I made one out of plexiglass. That was the second generation. Then I bought one somewhere, it was a third generation. It was actually a real wheel. And then this last one, because now you can get anything on Amazon, it's the absolute winner. So we went through four of those. I wish I had the other three for our museum, but that was biopsy conference number 2 was there. And then when COVID came along, we changed things completely. We went remote. Ed was no longer practicing at that point, and we moved it to Zoom. And my point of this diatribe here is the fact that, biopsy conference was always meant to be a very educational experience. And one of the good things that happened out of COVID is it forced us to be so much more academic and collegial and include our colleagues, which have added so much to this, having people from all over join us, the different opinions. And we didn't get to almost any of the comments today. I apologize because we're so busy, but the great comments in the chat board. And I think Ed would be really proud. He never really saw this, biopsy conference 3.0, but I think he'd be really proud of it if he ever really saw it, because that was his whole goal, is to make this a very relaxed teaching conference, way beyond the typical model, which is a pathologist gets up there and goes from slide to slide and just shows pathology, as opposed to making it a case-oriented pathoclinical conference. And I think he'd be very, very proud of it, and we're very proud of it. And we would have never had it if it wouldn't have started with him. And Praveer, I'll hand it back to you.
So just a little quote, we this is a more inside thing, but in memory of Dr. Lewis, real nephrologists use 60 milligrams of prednisone. This was said by him to me at Rush Nephrology Biopsy Conference when I was a second-year fellow in October 2015. So fortunately, I found the pictures from that conference. So this is me when he asked me, how much prednisone would you do in this patient? And I said 40 milligrams. And all of a sudden he came out of nowhere and said, well, I don't know what you want to do, but real nephrologists use 60 milligrams of prednisone. So
as you can see, no one liked to have more fun with everything than that. I hope no one should ever misthink or think that any of this is disrespectful. If anything, it's of the absolute utmost respect to him, because he was a genius, but he was also a lot of fun. And I think he'd get a kick out of all this. So I think we'll end it there. Rest in peace, Ed, and we'll see everybody shortly.